Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Assessment of Primary Site Response in Children with High-Risk Neuroblastoma, an international multi-center study by Bagatelle et al. My name is Meredith Irwin, and I'm an oncologist at the Hospital for Sick Children and Professor of Pediatrics at University of Toronto in Ontario, Canada. My oncologic specialty is pediatric solid tumors with a focus on neuroblastoma. Neuroblastoma is the third most common pediatric cancer. Based on clinical and biological prognostic factors, patients can be divided into categories of low, intermediate, and high risk, and treatment is tailored accordingly. Survival for low and intermediate risk disease is approximately 90%, while those with high-risk neuroblastoma have a 5-year overall survival of only 50%, despite chemotherapy, radiation, surgery, myeloablative, and immunotherapies. In order to harmonize staging and classification of risk groups to be able to compare clinical trial results, international collaborations have been critically important. The International Neuroblastoma Research Group, INRC, published revised staging and risk classification guidelines in 2009. However, the guidelines for evaluating response to treatment, the International Neuroblastoma Response Criteria, or INRC, were last modified in 1993. There have been many changes in imaging and molecular diagnostics that were not used in the old INRC. Thus, there are ongoing efforts to revise the INRC, which includes response assessments of metastasis to bone, bone marrow, and soft tissues, as well as response of the primary site, which is the focus of the article that accompanies this podcast. This study was designed to determine the optimal approach for measuring the response or change in size of primary tumors following chemotherapy. To do this, the authors compare the current INRC 1993 volume-based method that requires serial three-dimensional measurements to the response evaluation criteria in solid tumors, or RECIST method, which relies on the largest diameter. The retrospective study includes patients diagnosed between 2000 to 2012 at 7 international sites. Because outcomes vary significantly between non-high-risk and high-risk patients, only the latter were included. The analytic cohort includes 229 patients with high-risk neuroblastoma, most of whom were greater than 18 months with INSS stage 4 disease and/or MECAN amplification. All patients received similar induction chemotherapies. The 3-year event-free and overall survival rates were 44% and 58%, respectively. Demographics and outcome data are similar to that of recently published high-risk neuroblastoma cohorts. Study radiologists obtained measurements from 2 time points during induction chemotherapy prior to surgical resection. These included 3 dimensions to calculate volume as per the 1993 INRC. They also determined the longest diameter as per RECIST criteria. Complete response was defined as no residual mass. There were 3 different partial response, or PR, measurement methods used. Specifically, using RECIST, PR was defined as greater or equal to 30% reduction in the maximal diameter. Using INRC, a PR was defined as greater than 50% tumor volume reduction. In addition, the authors also analyzed a third PR, which was a 65% volume reduction, which corresponds to the 30% diameter decrease using RECIST. The authors compared the sensitivity and specificity for each PR measurement. They defined sensitivity as the ability to identify patients who survive, and specificity as the ability to identify patients who ultimately die. Sensitivity was highest for the 2 volume measurements at 72 to 79%. However, the most important finding was that specificity was universally low for all three methods, and none predicted the ability for surgeons to perform a complete resection. Moreover, in multivariate analyses, neither the INRC approach, change in volume, or RECIST, diameter change, was independently predictive of outcome. Given the heterogeneity of neuroblastoma, they repeated these analyses for subgroups. In contrast to the negative findings for the whole cohort, in the subset with MICAN amplification, those who did not achieve a PR based on volume changes of 50 or 65% were 3 times more likely to die from disease. The significance of this report is that it is the first study to compare different methods of measurement in a large multi-center cohort. The overall conclusion is that the sensitivity and specificity of INRC and RECIST-based primary tumor response methods were not significantly different for high-risk patients. Thus, they recommend using RECIST criteria to evaluate primary site for the next INRC. Another advantage cited is the fact that longest diameter measurements are simpler to perform and likely to be more reproducible. There are several possible explanations as to why the current study did not identify a strong independent correlation between primary site response to chemotherapy and outcome. For high-risk neuroblastoma patients, the majority of whom are stage 4, the upfront response of metastatic disease may be a more powerful predictor of outcome and thus overshadow the effect for primary tumor shrinkage. For high-risk neuroblastoma patients, the majority of whom are stage 4, the upfront response of metastatic disease may be a more powerful predictor of outcome and thus overshadow the effect for primary tumor shrinkage. Interestingly, several studies have shown conflicting results as to the benefit of a gross total versus partial surgical resection of primary tumors for high-risk patients. In most of those studies, an acknowledged limitation is that the authors do not examine the role of metastatic response in predicting outcome. With current era therapies, we know that most high-risk patients relapse in the bone and/or bone marrow and rarely have isolated primary site recurrences. Moreover, many large studies have demonstrated that quantitative assessments of metastatic response on MIBG scans or minimum residual disease in blood or marrow following chemotherapy can predict outcome, and this data further supports the notion that isolated primary site response to chemotherapy is unlikely to have strong prognostic significance in predicting survival for the majority of high-risk patients. Thus, the updated INRC overall response guidelines will also include quantitative assessments of bone and bone marrow metastatic disease, both of which may be influenced by the response to other components of treatment, such as immunotherapy. It is important to note that although for the full cohort the ability to predict an event with RECIST was not significantly different from volume measurements, the authors did detect at least one subgroup in which volume-based response was prognostic, those with MICAN-amplified tumors. While it makes sense to keep the INRC measurement recommendations simple and harmonized for all patients using RECIST, this data may inform ongoing efforts to identify early markers for the poorest outcome high-risk subsets of patients who are destined to recur. Furthermore, it suggests that if we look specifically at well-defined genetic subgroups, it may be possible to identify ones in which primary site response is predictive of outcome. In addition, there were no patients with non-high-risk neuroblastoma, which accounts for more than 50% of all patients. Thus, it will be important to determine whether primary site response using either measurement method in non-high-risk patients correlates with outcome. Other areas for future study include whether the impact of primary tumor response differs based on abdominal versus non-abdominal locations or correlates with image-defined risk factors. Whether primary tumor response is only prognostic in specific genetic subgroups or may identify groups needing different local control strategies also requires additional studies. In conclusion, the findings from this manuscript support adopting the longest diameter RECIST criteria for primary site response in the new INRC. Prospective studies with central review and correlation with other clinical and biological factors will be required to determine whether tumor response using RECIST criteria is independently prognostic for subsets of high or non-high-risk patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.